I'm Trish DANTONIO. I work with the Gerontological Society of America. We are a professional membership organization, and we are happy members of the Protecting Access to Pain Relief Coalition, or PAPER. And I know in the introduction we talked a little bit about the PAPER Coalition, but we were organized in 2015. And my job here today is to talk to you about why it's important that many coalitions that are successful part of that is the diversity of our membership. So we joined the coalition formed in 2015, and the FDA had issued a report that they had planned to remove any strengths higher than 325 milligrams of acetaminophen to be available for consumers in the over-the-counter market in late 2014 or early 2015. And that was as a result for something to protect the public. You probably remember some issues in public press where there were overdoses of acetaminophen. There was confusion about how to take, so when I talk about acetaminophen, I'm talking about Tylenol. There were some children who had overdosed, right, because we know that Tylenol exists as itself when we purchase it. It exists in combination products. It also exists in some of your prescription products. So people didn't know how much Tylenol they were taking. Not to mention that some people didn't understand that Tylenol was acetaminophen and also could have been referred to as APAP some places. So there was a huge effort in the medical community with consumer groups to be sure that we educated consumers about that, make sure there was more consistent labeling, make sure that there was more consistency around child dropper bottles and how we talk about take a teaspoon and what that means. And that can cause some confusion for people, and making sure that it was measured better. So with all of that, there's still issues where somebody might abuse acetaminophen. If they take too much, it can cause liver trouble. And it could cause some very serious liver damage and lead to some untoward consequences up into death. So rightly so, there was an issue about this. But of course, with every issue, when you take one action, there's going to be some unintended consequences for other populations. And where our coalition formed was because there are so many other people who are impacted by the fact that, well, what am I going to do for pain on a Saturday night if I'm not able to have access to the strength of acetaminophen? How many tablets do I have to take to get that same pain relief? And it really didn't, if you think about it, it really didn't address the issue that maybe the FDA wanted to, because if you could take a 500 milligram tablet and that was going to be enough for you to address your pain, that's going to be enough for you to address your pain. But if the only other option on the market is 325 milligrams, when you take two, you're now taking 650 milligrams. My background, I'm a geriatric pharmacist, or I'm board certified in geriatrics. I'm not an old pharmacist, but and one of the things that's always important for us is we're trying to think about how not to have people on so many medications, right? Because not just the number of different medications you're on, but the number of pills that you're taking, that pill burden, right, which you all know about, can also be a problem and a reason why somebody might not be as compliant, or why it can cause some confusion or trouble or other challenges with your medication. So we formed as a coalition to advocate and to educate members of Congress, and members of the administration about some of the other issues that they needed to consider if they were to remove this strength of medication, and what kind of considerations we thought needed to have. So the coalition, we have 23 members now of different types of organizations. Our organizations are, Paul is our chair, representing the kidney patients. We have other kidney organizations that are members, right? Because of the issue of non-steroidals. We have health professional members. So we have the American Pharmacists Association and the Academy for Preventive Medicine, so representing physicians and nurses. We also have the U.S. Pain Foundation and other pain organizations, because in chronic pain, you need to have a broad armamentarium of both medications and non-medication treatments to treat pain. And then for the Gerontological Society, we were interested for the reason that I had briefly stated and we talked about in my introduction, is that for older adults, you wouldn't want to use nonsteroidals because there are issues around GI bleeds, so ulcers, and issues around cardiovascular events that have been documented. So you need to make sure that you have things available. And what we often talk about when we go on the Hill and we're trying to describe this is, on a Saturday night when somebody has pain, it's not going to be easy for them to go to the emergency room necessarily because maybe they are an older adult. Travel for them, transportation for them might not be so easy. Their children might live out of town, right? So it's not just an easy jump for them to get there. And there might not be a practitioner available, right? So now they're going to have to go to the emergency room if they didn't have medications available. And also, some of the issues around this that become challenging are that we don't want everybody on prescription medications. We don't want them to jump to opioids or other medications that they might not need to be able to manage their pain. So we started visiting with members of Congress. So we took an organized approach to that. And we met with members of the Kidney Caucus. We met with the Senate Special Committee on Aging. We met with other appropriators, others that had oversight of the FDA, to make sure that they were aware of this issue. And certainly, we heard from staff. They were certainly concerned to hear about this. There were some staff, when you go in and you're educating them, and this is one of the things that's really good about having a broad group of people gone in to visit, is you're not sure which story is going to speak to a staffer. And sometimes, Paul can get through with what he's talking about with his experiences because he has that direct experience with being a kidney patient himself. Sometimes when we're talking, it's because I can get through to somebody and relate to them with respect to their grandparents and what it might be like for them if they were in pain and they needed to have access to pain, appropriate pain relief. So we worked in 2015, 2016 up on the Hill. We started to then meet with the FDA. And because we were a broad coalition, when we sat down, we actually were able to have successful meetings with the Office of Patient Engagement. And what was remarkable about that is they always brought several members of their team to meet with us. And we met with John White, who just recently left FDA. And he would always comment that when we would come up 15 strong to go visit the FDA and talk to him. And we were trying with his team to work on a project where we could show that we were actually changing the way, changing behavior that that consumers really were getting it about what they needed to do for taking Tylenol appropriately. And we worked with them for about a year, developed a grant. And the grant was a little bit different because we were talking about some gaming theory and behavior change, which was kind of interesting because it wasn't just putting it out there like, okay, here's acetaminophen, here's your doses. People hear that, but you don't know if they really have digested that. We got all the way to the very end, and we did not successfully get the grant. But what was really great was, and this was our big win, is that when they sent us the letter to say, we're sorry, we're unable to fund this, they said, we really don't see this as a priority for us anymore. So now this is over 2 years of doing all this education at the FDA, with the administration, with members of Congress. And while this is not an official document, right? So we don't consider our job fully complete yet. But where we felt successful was in the letter where they said, we're sorry, we appreciated working with you, but we're not going to be able to fund this. But we also don't see this as a priority for us anymore. So we had been able to make enough inroads and education to show them that there were efforts out in the field to be sure that consumers understood how to appropriately take acetaminophen. And we also felt confident that we were able to educate members of Congress and members on the FDA team that the other issues that we might see or might encounter by taking this step would not solve the problem that they were trying to address, which would be to decrease the number of overdoses, and would also impact such a population when you consider the number of people that would be impacted by this, that they felt that this didn't need to be a priority anymore. So we've sort of transitioned a little bit in our work. And one of the things that we've spent some significant time doing recently is making comments to some of the pain task forces that have been stood up from, whoops, there we go. So because of opioids, right, we know that there are studies now that show that acetaminophen is just as effective in chronic pain for your knees, acetaminophen and nonsteroidals as opioids, and you have less poor outcomes as far as side effects go. So we're making sure that that information is out there when we're talking about the opioid crisis, the importance of other medications. And we know that everybody knows that because something's over the counter, it can't possibly work like a prescription drug can. So, and I say that facetiously, but I do know, having worked with some patients, they really feel like they have to have that prescription or it doesn't, it's not going to work the same for them. But now we're starting to get that evidence that shows that the over-the-counter medications are just as effective. And it's important for people to know that, for policymakers to understand that, for consumers to understand that, and for practitioners to understand that, so that we're sure that we're addressing people's pain correctly. So we continue to meet with Office of National Drug Control Policy. We meet with the White House. And we are meeting with members of Congress still, making sure that they understand the importance of this and that they still see the strength of our coalition, because we are diverse, because we do come from different perspectives, but we all have this one goal to make sure at the end that the consumer is treated appropriately and has the right medication that they need for the right challenge that they might have at the time. So with that, I'm going to just check my notes, because I noticed I didn't even look at all my notes that I wrote. But I would just say one thing. Since I'm sorry that Paul's not here, but it is a pleasure to work with Paul and the coalition. He keeps it light, even when it gets pretty serious, because sometimes you go into a room and people don't want to hear what you have to say, but he's able to keep it in a way that everybody understands that it doesn't matter what your philosophy is in other areas, because we are concerned about patients at the end here. He's really able to keep us together as a group focused on that mission. So it's really a delight to work with him. And I really do feel honored to be able to work with him. So thank you.